all of those examples that I just mentioned now have a shared task, and that is to cope with the sleep disruption. And how do people cope with sleep disruptions? Many, many, many different ways. But some common ones include things like going to bed early, turning the alarm off and sleeping in a little, or hitting the snooze bar an extra couple of times because you're tired. Winding down with a glass of wine or some weed before bed. Trying to take a nap. Engaging in some sleep effort, things like I'll do a sleep, I don't know, like a sleep podcast or a sleep app. I'll use like some sort of app or something before bed. Just anything like that. All reasonable. There's nothing dysfunctional about any of those things, but all of them have the potential to map onto these three causal factors that occur whether you have a comorbid insomnia, an insomnia without a comorbid disorder. These are the three things that convert a occasional insomnia to insomnia, the disorder. Only three causal factors, and these are them. One is a decreased deep sleep drive. Okay. One is a clock problem, and one is conditioned arousal. So those are the three things that CBTI was made for. People with insomnia, whether they have comorbid problems or don't have comorbid problems, these remain the same three. And this is a mistake that many people who treat other disorders make. So when they have somebody with PTSD, they'll say, well, of course they have insomnia, they have hypervigilance. And so they will attribute it to the disorder. And the issue with that is, I'm not saying that hypervigilance can't be a factor in causing an insomnia symptom. For sure it would. However, over 50% of people who are successfully treated for PTSD continue to have insomnia disorder after treatment. And that's because there's nothing in prolonged exposure or cognitive processing or EMDR that increase sleep drive. There's nothing that regulates their circadian system, and nothing that gets rid of the pairing of the bed with wakefulness, nothing. And so that's why they fail, because they have not addressed what the primary problem is. So you need to reprogram yourself into thinking about comorbid insomnias as having these three components.